Now, I'm guessing that a number of people will have slides like this. I will say we got fantastic advice last year from both the Federal Coordinating Council and the Institute of Medicine, both of whom in turn were informed by broad stakeholder input. And what I find most striking isn't differences, but actually how similar these two groups working almost entirely independently were. We did not, at the Federal Council, have the top 100 questions. If I had to do it again, maybe we would, but just a catchy way to get people's attention. But a very strong focus in both reports on infrastructure. So I'm going to give you some specific examples. You wondered how we're spending that 24%. And here you have it. We're trying to make available some of the department's strategic assets, whether that's Medicare or Medicaid data. We're also working with states to figure out how they can enhance their billing claims with clinical electronic data elements. Very excited about work we're investing in at AHRQ in distributed networks and enhancing registries. And the list goes on and on. The cancer registries is being done at CDC, and it's something I'm particularly excited about because the end game here is to get better, more accurate information, but also to be able to follow people over time. So at some point in the not distant future, you could imagine that we would actually know for the most common cancers, how are most people treated? Where are we? And we simply don't have that information right now because it gets hard to follow people after the initial diagnostic point. It's not beyond our imaginations. The work they're doing is a very, very important down payment on that. There's been a lot of focus as well this past year and discussion about making sure that this research addresses the needs of what I will refer to as priority populations. That's a term from AHRQ's legislation. I'm talking about people who are traditionally not well represented in usual clinical trials and other studies. That can be people who are members of racial or ethnic minority groups, people who are disabled, people with multiple chronic illnesses, the elderly, and so forth. And one way to actually get better research, besides changing enrollment rules, is to actually build data resources where those people get care, so you can see the community health center network and so forth. This just gives you a sense of how the methods and scientific underpinnings of comparative effectiveness are relevant to many parts of HHS, from FDA focused on post-market surveillance to the Office of Minority Health and CMS and so forth. This has been really a team effort and one that has been very, very exciting. This last bullet just refers to we had a specific council to literally focus on integrating and coordinating these efforts. Some specific investments that are coming from AHRQ very soon, that is to say the solicitations have long since closed, and we're just close to making funding decisions now. The CHOICE initiative, prospective large-scale clinical studies, focused with a strong focus on people traditionally not well represented in studies, more work on registries, more support for the DECIDE consortium, and so forth. And coming later this summer will be a citizens forum. Now, this, I think, is going to be critically important opportunity to promote all kinds of dialogue about what is it that we're doing here, how do we use this science, how can we make the use of this information as transparent as we've tried to make its development at AHRQ. I'm sure you'll notice this rolls right off the tongue. Easier to say than to do, but again, this increasing focus on using science to influence and inform policy really demands that people understand the details of how it's done. First, it demands that we, the scientific community, do it well. Then it demands that the details are transparent and credible to the American public. Many of you, I know, are very, very excited about the Patient-Centered Outcomes Research Institute, as are we at AHRQ and NIH. In case you've missed the news bulletin, nominations are due June 30th. Now, again, you can see from the language of the legislation prohibiting findings to be construed as mandates and so forth. Strong concern persists about how this information will be used. So getting the details, methods, analytic underpinnings right is going to be quite critical. I will also say for the new center, we have a terrific opportunity. About 16% of the budget will come to AHRQ for dissemination and for methods development. Now, this slide is much of what is in the Affordable Care Act and all of our shared aspirations for improving health care is really about transitioning from a health care system which has a lot of challenges, but I mean where all of the action is focused within specific settings, right? You're in the hospital, then you go over here and so forth, and we aspire to make this a team sport. It doesn't always work as we'd planned, and most individuals actually want to know about the whole journey. So this is a sneaky way to let you know I got an iPad. I'm not endorsing it for those of you who are wondering. But the point is that more and more we've got to figure out how is it that we can reach individuals wherever they are. So if it takes the ad council and kind of edgy ads, or it takes other strategies, we're all for it. All of this is very much about improving quality of care, and for all of our challenges in getting methods right, we're way, way better at measuring than improving, and government clearly has a very, very strong role here. But where it really begins to overlap with directions for improving quality is this transition from a setting-specific approach to one that is really patient-focused. Everything about outcomes research, and I've never tested this with Mike Lauer, but I'm guessing he would agree, has been about trying to follow people over time. Not just looking at what happened the day you had a heart attack, but actually seeing what happened 30 days, 60 days, 90 days out. We're coming to a place between adoption, increased incentives for adoption of health IT and other efforts, where this is actually going to be increasingly easy. And I think many, many patients are going to want to be part of this enterprise so that they can know for themselves and people they care about what happens to people like me if I choose this path, that path, or another path. But we've got a lot of work to do moving forward, but I would assert that that is very much part of improving quality of care. And I'm always reminded by a famous quality expert from Boston, currently the CMS nominee, a CMS administrator nominee, who said many, many years ago, at the end of the day, only those who provide care can improve that care. So I think we've got a critical opportunity and an obligation to make this easy at the front lines. So just a couple of thoughts in closing. All of these infrastructure investments, I would assert, are A, important, and B, can be leveraged for efforts to assess and improve quality of care, for efforts to do a much more robust job with post-marketing surveillance, and frankly to inform risk communication about new products, new developments, and so forth. If we lose sight of making this easy at the front line, we will have missed a huge opportunity. And the last thing I would put on your agenda, just because I think it's exciting and overwhelming both at once, is both the Institute of Medicine and the Federal Coordinating Council concluded that the definition of comparative effectiveness had to be broader than clinical interventions. I think this is incredibly exciting. Shelley Greenfield may have more to say about that later. But both concluded that it had to include care delivery interventions. Now, we all know what 20 milligrams of a particular medication is. We don't always know if people are taking it, but it has a standard meaning. We simply don't have that on the care delivery side. So you can either look at this as overwhelming or exciting. Most days I think it's very exciting.